We have a panel now that is very important, and I'm going to briefly introduce the three speakers. The panel is called A Cultural Shift in the Acceptance of Breastfeeding, Expanding Community Supports for Mothers and Fathers at Home and at Work. Now, I know this resonates for all of you, knowing full well the complexities of supporting breastfeeding. We have three really terrific speakers. I'm going to briefly introduce them all together, then they will each speak, and then they will be here for questions and discussions, questions from you and discussions among themselves. So first, known to many of you, is Kimarie Bugg, who is really an expert on this issue in community-based environments. She's the president and CEO of Reaching Our Sisters Everywhere, affectionately known to all of us as Rose. And Rose addresses breastfeeding inequities and disparities in the African American community. She has worked on important initiatives that we all know and love, like the Baby Friendly Hospital Initiative, and also works with USBC and with WIC. Not surprisingly, she and her husband have 5 adult wonderful children. So that's Exhibit A. She's terrific. We're also really pleased to have with us Dr. David Bell, who's an MD and MPH in adolescent medicine in New York City. He is the medical director at Young Men's Clinic at New York-Presbyterian Hospital. He also is on the board of Promundo, which works with African American men, and this is clearly a very important target audience for us, and he can give us some insight about that population and the importance of supportive fathers. Last but not least on this panel is Jessica Lee, who is a lawyer, a staff attorney at the Center for Work-Life Law at University of California, Hastings College of Law. As you just heard, she works to make sure that there is knowledge and support of implications for Title IX, which is the federal anti-discrimination laws, in terms of students in universities, and particularly the program she just mentioned, Pregnant Scholar Initiative. So they bring yet another set of perspectives to us, and I hope you all appreciate what they can do to expand our notion of this little area of breastfeeding and its absolutely huge implications. So let's start with Kim. Thank you.
Thank you so much. Black women do breastfeed. I am going to start this crucial conversation off, our panel discussion off, on talking about equity and the community and Black women and breastfeeding, which is all some of my most favorite things. But one of the things I would like for you all to know is that Black women do breastfeed. And we breastfeed for a long time. We tandem nurse, we have problems, we go back to work, we go to school, we do all kinds of things. This young lady is one that won one of the programs, one of the prizes to our summit this year. We have several times a year that we ask mothers to send in their breastfeeding pictures. And this has happened to be a young lady that I knew as a teenager, and she's an old married woman now. And so Nixon is 3.5, and he did wean about a week ago, made us all sad. And Cameron is 5 months old. So she started off as an intern with us when she was in high school many, many years ago at a community clinic where I was a nurse practitioner. So mentoring makes a difference also. This is a conference I was at a few months ago, and this conference consisted of about 300 women and there were about 2 men in the conference. And so this was in Columbus, Ohio. So what the Marriott did was took the 2 large restrooms that were in the area and converted the 2 of them to women's restrooms. So these are fresh flowers. They put these inside the urinals and put on the outside, that this was women's restroom. And, the 2 men, they told them they could go up to their rooms and use the bathroom or go somewhere else. But I felt that, when I went in to use the restroom and I saw this, I said, this is what equity is. This is equitable. There's so many people and places and healthcare providers that I work with all the time that have no idea about the true concept of equity and equality and, the reality. And, a lot of times when I'm working with nurses, I'm a nurse, and I will say, define equity, and you get 10 different answers. So this is providing the population at need, the target population of 298 women with what they need at the time that they need it. And these 6 stalls, when we need to go to the restroom with those big conferences is exactly what we needed. So I just thought that was such a great way to discuss equity. And I would also like to say that racism does make us sick. On several committees, and Dr. Long and also Dr. Young, that discuss, infant mortality and safe sleep and all of those wonderful problematic things that we know that there have been serious gaps in from the beginning of time, but everybody wants to say, why isn't all these fabulous interventions that we're doing working? Why we're putting tons of money into this, and we are doing all these wonderful things, but nobody wants to mention racism. Nobody wants to talk about systematic institutional racism. And that has to be part of the conversation in order for us to move the needle, in order for us to talk about healing, in order for us to talk about post-traumatic slave syndrome. We have got to at least mention the fact that the system was not designed for us to make it. And therefore, it's changing, it's, really adapting. We're doing some fabulous things, but we got to talk about where we came from to know where it is we need to go. So again, racism damages my heart, my blood pressure, and my unborn baby. That DNA is there. So many people have talked already about the breastfeeding statistics. I've had the opportunity to do this for a long time. I'm an old person now. And I have been in rooms with, 200 nurses, and I say, okay, raise your hand if you were trained in lactation management in your professional training. And so out of 200, I might get 2 people who raise their hand and say, I was trained in lactation management. And these are in the same way with physicians and, nutritionists, all of us. Nutritionists will tell me, well, I learned about the composition of breast milk, but nobody was taught how to put babies to the breast, right? And so those have always been some issues. But the latest statistics here say that, where's my African Americans? Okay, yep. Oh, so it says 66.3 plus or minus 3.6. So my thing is, I'm going to claim that 3.6. So 70% of African American women are initiating breastfeeding. I see that when I travel, when I'm working with people, and we do work throughout the country. The change has been dramatic. There are so many more, the churches that we work with, so many of the places that we're working with, there are so many more women now who are initiating breastfeeding. The gap remains, and the gap's gonna kind of remain until we work on some other issues besides education. And that's what we hear so much in a lot of these forums is, oh, we gotta educate folks. And that's been been going on forever, and education is definitely necessary, but we've got to move beyond that, and we're going to talk about that with the community, and I'm going to talk real fast because Carla going to be waving me off pretty soon. So the importance of breastfeeding is something that we need to stress, and we need to stress that through programs, through policy, through partners, and I put peers last because those are my most favorite people on the face of the earth. But we've got to address all of these issues. And I'd like to say that, these are some things that we started to address when we initially got started with reaching our sisters everywhere. We sort of pulled out the Surgeon General's call to action and started going through that and truly addressing and working on those action steps. We've been told that it takes about 15 to 17 years to bring evidence off the shelf and put it into practice. And I guarantee you it is so true. And when they were saying that, I'm like, that can't be so. But we've been working with the Surgeon General's call to action for 5-6 years now. And I tell you, people are just amazed. Wow, that's so wonderful. How do you know how to do that? It's in this little blue book, truly. And so again, repetition, but all of these wonderful things have sort of come out pretty much that. And I just like to say, this is one of my favorite slides from a good friend, Linda Smith, that the breastfeeding, breast milk touches every organ system in the body, every one. Every system is touched by breast milk. That is absolutely amazing. Can you think of anything else that does that? And somebody said to me one day, water. I'm like, good thing it's 70% water in breast milk, huh? And this was somebody really smart too. But, they just wanted to make it, something else. Okay. And one of my other really good articles that I love is the one with Dr. Bartik and all these other folks, Melissa. So what I continue to hear time and time again in communities of color, reasons that, breastfeeding initiation and duration tends to be so difficult is, first of all, the concern about not making enough milk. From the time a woman has a baby to the day that she weans. If she weans that child when he's 6, she's still concerned about not making enough milk. And so that is something we need to address from the beginning. As someone else was saying, to just talk about, as Dr. Brown said this morning, the size of the stomach, the need to do skin to skin immediately, what that does with getting milk started. The other concern that young people tell me, and I keep young people around me all the time, I used to say I was really cool because I had all these kids and I had them sort of in different age groups. I had I had 2, and then they were 12 when the next ones were born. So they were teenagers and helped keep me cool. And then the other ones were babies, and then they left. And then I had these other ones that were teenagers, so they kept me cool. And then we had what I said oops, and my husband called an unexpected blessing when we were older, and he just graduated from college, and he kind of kept me cool. Now I have no one, so I'm no longer really able to be cool, but I do keep, because it's important to know what their concerns are. I have been in rooms with people making policy, and I was the breastfeeding policy, and I was the youngest one in the room. I was 55 years old. And so I'm saying, so who in here, I know me, I got powdered milk in my breast. Anybody in here can breastfeed? And so, you have to consider that when you're developing policies and programs. So a group of students from Clark, Atlanta, and decided to buy McDonald's and pizza for the students and ask them to go in the bathroom to eat it. And the whole thing was, this group had found that people being told to go breastfeed in the bathroom was a major reason why young people didn't want to breastfeed. So they bought all these folks the food and had them go in here, and they said, do you want to eat your lunch in the bathroom? And these were very successful in the Atlanta area. So some of the other things that we know we have to do with the community, it is absolutely imperative that we tell them how to breastfeed, that we teach them how to. We say, go forth and do. That don't work. So if you haven't had models, if you haven't seen folks breastfeed, and it is getting much, much better. We're seeing more and more people breastfeed, but we need to not just say, oh, it does all these 500 million things, and, you need to do this and go forth and do it. We need to discuss the fact that you need to breastfeed and not supplement and not give pacifiers for the next month. Nobody's saying you can ever give a child a pacifier, but it's necessary to establish breastfeeding before you do, and to make sure that they know that there are those little laws that say that you don't have to breastfeed in the bathroom. That just empowers people. It's going to depend on their behavior anyway. But if you tell people there is a law that says that you don't have to do that, that does empower them somewhat. They can go to, Victoria's Secrets, where they're told that you can't do that in here, when it's 9 feet posters on the window of women in push-up bras, and women are telling they can't breastfeed in there. They can tell them, well, there's a law that says that I can. And young people have been doing that, so I've been very proud of them for that. So, community. What is a community? It's a fellowship with others as a result of sharing common attitudes, common interests, and common goals. Dr. Brown mentioned this morning that he can go in and say, look, you can breastfeed this baby. And folks say, oh, okay. I saw a lot of people kind of grimace, but I've done the same thing. I've had people come to work with me in the hospitals and see how we do rounds. And I ask women, so, how are you going to breastfeed your baby? And they would say, well, I guess I'll pump it out and put it in a bottle and give it to them. Folks who never thought about breastfeeding. I'm like, well, that's one way we can do it. Or we can just put the baby to the breast. So it is the message, but it's also the messenger. People don't care what you know until they know that you care. Once you've established relationships, and that's what it's about in our community, it's about relationships, then they trust you enough to say that, well, you know what, if you feel that I can do this, then I'm at least going to attempt to do this. So one of the things that we do is called a community transformer, where we train women to be peer-to-peer helpers in their communities. And we've worked with residents and airline pilots and accountants and, women across the board. Of course, lots of doulas and birth workers also, to train them on the evidence-based information so that they can work with and help their communities. Now, well, we'll get to that in a minute. And these are just some of those women that I've talked about, some accountants and, medical school residents and lots of different women who all have that common goal. Everybody wants what's best for their babies. They truly do. Partners, grandmothers, aunties. Aunties I absolutely love because, they're kind of in between. They're not a sister, but they're not a mama. And aunties are really still pretty cool. So we love to pull in aunties to help them to understand what the evidence is so that they can make sure that we can make sure that mothers are getting accurate information. Again, someone mentioned, and you're going to hear this a lot because so much of what folks were saying did resonate with me, the fact that if you ask somebody about breastfeeding, if you ask 5 nurses in the hospital, you might get 5 different answers. And then you wonder why nobody wants to sign up for that program. They're like, if you confused, why do you think I'm not going to be confused about this? You will get 5 different answers. Pastors, there's so many scriptures in the Bible about breastfeeding, about 200. That was one of the things that I gave to my pastor a long time ago. And if he come across one, he'd lay there he'd hover over it for a little while and he'd look over at me. And after church, he said, did I do okay, Sister Kim? You did all right today. So hairdressers and nail shop owners, again, need to have some information, just like someone else said today. It's not just about who, is immediately touching the moms. It's about other folks in the community where they spend a lot of time. So we know that culture is expressed in many different ways. And then we have to add to it, the genders and the family dynamics, personal psychology and age, and all of these can definitely impact where it is that we need to be. But we need to talk about being culturally competent, not just aware. We moving away from awareness. We've come too far now to just be aware. It's time for us to act appropriately. So cultural competence is emphasizing the idea of effectively operating in different cultural contexts and altering practices to reach different cultural groups. It is imperative, especially when it's our job, when we're getting paid to do this, to assure that we are competent in addressing the needs of the population or the people that we're working for. I remember a family coming in to our facility many, many years ago, and the family wanted the baby's head shaved. And so I'm working in a hospital that, 89% of the nurses are African American. And so what do African Americans value? My few in the room. Okay. And so when they said they wanted this baby's head shaved, everybody said, oh, call protective services. Something's wrong with these people. And so it was very difficult. And I was the nurse in charge that evening. And I had a problem with it. I called everybody and they finally said, okay, give the father the equipment to do it. And, I stood there and watched him and make sure he wasn't going to hurt my baby because it wasn't his yet until they leave. And they did it. But I mean, their religious leader was there, their family was there. This was important to that family. So we had several after that, and it was a little easier, and we started helping them. But it was that first time we were not culturally competent. We wasn't even aware. We wasn't in any of that stuff. And so it is important. And I just have to mention implicit bias. We all have it, and we need to be aware of it and claim it, and so that we can work on sort of being culturally competent when it comes to our specific biases. Again, I was recently Christmas at a real nice hotel in Miami. My son was in law school there. And so we, all kids are grown, so we go there and just so we can sit on the beach on Christmas Day. And, I'm able to do all this traveling now, so I have all these wonderful points for hotels and stuff. So I'm staying in the hotel with our little points, a really nice hotel. And it was a group of young people and that were speaking the language, and now it kind of sounds, I don't know what it was. So when my husband and I, who's older than me, sat down next to them, the young lady took her purse and moved it real fast, and I mean that hurt my feelings. It really did hurt my feelings at first, and then I was like, okay, first of all, how many old Black people has she seen snatching purses and running? But, I can laugh and joke about it, but what she'd seen on TV in America really, made her think, I guess, that I was going to snatch her pocketbook. So, I had to start calling, and look, come on, Dr. Young, smile, come on. I started, I just tried to talk to her and let her know that, I was all right. I didn't need her pocketbook. Baby friendly has come up, it's come out. It is one of the things that can truly, truly promote equity. It truly can. We have got to promote and support and enhance baby friendly because, again, a rising tide will float all boats. If it is policy, then it will make a difference for everyone. So we truly do need to promote this. And I just wanted to also mention, I saw one of those slides from Clarksdale, Mississippi. Mississippi, that's the Delta. We do a lot of work in the Delta. Maternal mortality rates rival some third world countries, and it's a wonderful place. We did a session for Community Transformers. We had over 20 women, and when we started to go down there, they said, you will not find one person, especially one Black person down here, who has breastfed. So you wasting your time coming. We found about 25, and of those 25, not one of them breastfed while they were in the hospital. And those were the people we were talking with. And we asked them, and they were breastfeeding toddlers, some of them then. And so we asked them, why didn't you breastfeed when you were in the hospital? Nobody knows you're breastfeeding. They said, nobody told us we could. This is 2013, December 2013. They said that nobody told them they could breastfeed, so they did not. So again, do support this. And one of the other things is that every place we go, we've been working with Mississippi a lot, they, in all the hospitals, they say, we refer moms for number 10 to WIC. And so I said, well, has WIC been in the room with you? Have you told them you're referring? Absolutely not. So they're not developing those partnerships either. And that is also important. So lots of African-American groups that are promoting breastfeeding. DC Breastfeeding Coalition is phenomenal. The Blacktivist is a group on Instagram that has tons and tons of African-American women breastfeeding pictures, which makes a difference. Women of color need to see other women of color breastfeeding. Baby Bliss is in Delaware. There are lots and lots of breastfeeding social media groups. And this is one of the other things we've been working hard to do, is to develop cultural coalitions. So this is the one that we have just started in Atlanta, because the regular state coalitions are not at all addressing the needs of African American women. And so until they do and feel comfortable doing that, then, you know, we're gonna have to develop these. And so there's one in Pittsburgh and Memphis, Sarasota, Florida. We just started this one in Atlanta. To specifically address the needs of African American breastfeeding women and infant mortality, as they have mentioned, is our goal, decreasing infant mortality. How many of you know about It's Only Natural? Okay, good number of folks. Again, in a room with 400 or 500 people, it'd be 2 people in the room who've heard of It's Only Natural. It's a phenomenal program that has videos, it has leaders' guides, it has fact sheets, it has how-tos on how to breastfeed that's targeted at the African American woman, and it's all online. It is a phenomenal program. Promote it if you're working with women of color. I hear so often when I go to these hospitals across the country, working with the nurses, who I also call my tribe, they are. How do you talk to these women? So, you know, I say, okay, USA, work through this implicit bias. And, you know, especially, you know, one of the wonderful things is the state of Mississippi has actually stated that every hospital in the state has to be on the baby-friendly pathway. This is the Blue Cross Blue Shield is mandating this for them. And they've had some serious pushbacks, but Blue Cross Blue Shield is going forward with it, and it's truly making a difference in the hospitals getting on board and working with the CHAMPS program to do this. But It's Only Natural is a phenomenal program that's free. And then someone's already showed the breastfeeding guide. These are a couple of African-American-led lactation programs. NAPLC, National Association of Professional and Peer Lactation Supporters, PEERS, CLCs, IBCLCs, Academy of Breastfeeding Medicine Physician, ours, and are all involved in NAPLC, and they are a national organization. And then Black Mothers Breastfeeding Support, they have 128 mothers, 128,000 mothers that are part of this organization. And they're phenomenal. I'm one of the admins, and I try to stay out of it as much as possible, but occasionally they get a little special, and I have to go in, like they were saying, you know, Gatorade will increase, you know, breast milk. And I'm like, okay, it's not harmful. You can drink some Gatorade. And so then it got to the point, but it has to be blue Gatorade. So I'm like, Okay, that's gonna make you pee more. That's all. It's not going. You don't have to specifically drink it. Some phenomenal books that help us to understand why it is where we are. Sankofa. You have to look back to where you've been to understand where it is that you're going. So these are some really phenomenal books that broke my heart, but I had to read through to help bring some peace to me when I keep hearing about, why, isn't that gap narrowing? It is very obvious and it's all in there, but it is definitely getting better. So equality is, something we've talked about forever and ever and ever. And you all have probably seen some of these pictures, but equality doesn't get everybody to where it is that they need to be. Equity is fabulous, but it's hard. It's hard at first. It's messy in the middle, and it's really beautiful towards the end. But what we know is reality. There's some people who start off in a hole. We start off again, the system was not designed for African Americans to be resilient as we are. And so some folks really start off in that hole, and some people start way above the hole. This is the last Bugg baby to have a baby. And this is my niece. She's 20 years old. At 18, she and Marlon graduated. They had to have each other. We all didn't like it, but he was in the military. So they just had this baby. I've gone to labor and delivery with 13 nieces and nephews over the years, right? And just like the physician said earlier, I never had a problem. My first hospital, I had my first set of twins, and I worked in. So I had a party. Nursing class after me were there. All 14 of those seniors were my label doulas. I did fine. Squatted, had them babies in 2 hours, two of them. Second babies, my husband is a neonatologist. Had the baby where he worked, the second set of twins. All his friends were there eating watermelon and having parties over me while I had my C-section. Nice and easy. They were taking Polaroids, no problem. Then my last one, my 18-year-old daughters were my doulas. They, went to sleep at 2 a.m. My husband, all three of them were on the couch sleeping. I'm being quiet, contracting so I won't wake up my babies over here. So nice. So this is the first time I didn't have to go. Because, my family before would have all these problems. People would be mean. People would be nasty to them. When I walked in the room, because I know all the folks in the hospitals in Atlanta, things would change. So I did not have to do this. They were together. She rocked. She sat on the ball. She got in and out of the water. They had this baby. They put her on her skin to skin. The baby nursed within 10 minutes. And they did phenomenal. I mean, I was up, ready to go if I had to, but I didn't have to go. And this is how it should be. It should not be because I know all those folks that I have to go and stand over them. And, my last niece told me, it was like, the heavens opened up when you and Uncle George came in. They were totally different, but that should not have to be. Everybody deserves to have equitable care, right? So they're doing real good. Okay. And that is all that I'm going to do right now because Carla said I had to go.
So I will start off by doing an informal CV or presentation for myself. It's like I am the odd pediatrician. And why I say that is I'm one, a pediatrician, but I'm adolescent medicine physician. But I'm the medical director for a family planning program, so I prevent babies most of the time. And then in addition, I work primarily with men, young men, ages 14 to 35, in sort of around primary care with focus on sexual and reproductive health. So this is a new topic for me, and sort of, but it's sort of, it's connected, and I'm connected in three ways. One is that I'm a father. And when my son just finished his first year in college, and in that context, when he was a baby, as an adolescent medicine doc, I do love kids, but I was so ready for him to be a teenager so that I could talk to him and like sort of do all the stuff I sort of thought about for working with teenagers. But I realized that I was a really light sleeper. And so that if my wife woke up to breastfeed, I was going to be up just sort of part of it. And so, right or wrong, I said, pump. And during the night, you can, sleep or pump some more if you need to. But the context is, I'll get up and feed the baby, Brandon, during the night. And it was one of the best decisions I made, partly because I was going to be up anyway, but it offered, at the time I was staying with my mother-in-law, so it offered me the only time that I had alone with my son in the first months of life. So it was really great, and it was sort of a great bonding experience. And so I actually share that story with my young fathers as sort of I go from the prevention stage to that they're having kids stage in my sort of service. The second sort of reason I'm here is, one, the medical director of the Young Men's Clinic, so therefore I have these sort of the captured audience of my patients. But I'm also in that context where another reason I'm here is I hadn't touched a baby except for my son sort of medically since 1992. And so in that context, I started moonlighting about a year and a half ago in the newborn nursery. And so that sort of brought this sort of newfound sort of round sort of piece about being with babies, being with families, being with fathers, as like in the newborn sort of setting. And that's been a very interesting sort of concept. So some of my viewpoints are talking with the doulas and sort of understanding what we do with fathers in the hospital as well. And the third sort of reason I'm standing here is that I've been on the board of directors for a group, Promundo, and in that context, they are a global leader engaging men and boys in promoting gender equality and preventing violence overall. And so I'm on that board of directors, and they've been doing some phenomenal work, and I'll talk a little bit about some of the global work they've been doing to sort of work with men and what that means in involving them in maternal health, and then transition to sort of breastfeeding specifically. I don't have any financial disclosures, but I do have one disclosure that I have been feeling I have to say. I usually don't speak with my computer in front of me, and I'm not sure if we received slides from me, but I thought that we did. But I usually don't speak with my computer, but the last time we had a panel, I'll turn 55 in October. And so I realized I had always been nearsighted, but at the last panel I realized I was farsighted as well. So I couldn't see anything, and I was just kept talking. So I had to bring my computer this time instead of trying to work from some other notes. So that's my personal disclosure. So there are two objectives of this presentation. One is to discuss the importance of supportive roles of fathers for pregnancy and breastfeeding, and then develop, hopefully, sort of think through the development of sets of messages, actions, and resources for fathers to be supportive for pregnancy and breastfeeding. So starting off, do I have slides by any chance? No? Okay, I'll just talk. I could. Yes, I do. Oh, I thought, for some reason, I thought there was communication from the last conference. And so, all right, that's why you don't have them. I'm sorry about that. I've been traveling a lot too recently. Let me get that for you. Sorry about this setup. I can still yes. Yeah.
It's because this is a rerun. In April, these three phenomenal presenters, all grantees of the Kellogg Foundation, did this fabulous panel at the Academy, the 25th Anniversary Congress on Women's Health for the Academy of Women's Health, and it was fabulous. And I just went up to all of them and said, how about a rerun? So it's the rerun, but I didn't pull the slides.
Right, sorry. And for some reason, I can't easily find it, but let's just talk and let's go from there. All right. So in 2016, a year ago, Promundo released the State of America's Fathers. And as I've reflected from growing up, my memories of my grandfathers and my father in their father role and how I've been a father, I reflect that the times have really changed overall. Fathers have, from the data that the Promundo released, fathers have increased time they spend with children by over 60% over the 30 years. Women spend an average of 66 minutes a day providing physical care to their children, and men spend less than half that. But 60% of men report a work-life conflict, nearly double the 30 years ago. And that sort of speaks to that men really want to be involved with their family and really are much more engaged than our fathers in the past used to be. Within that story, though, there's a tale of two fatherhoods. 8 to 10 million is the estimate of the total number of non-resident fathers in the US, and 2,700,000 children have an incarcerated parent. 10% of children have a parent who has been in prison. This represents many challenges to foster healthy fatherhood and sort of family relationships. Of note, though, when we engage men in maternal health, women exhibit more positive breastfeeding practices. Women experience less pain in labor and delivery. Women attend more prenatal and postpartum visits and are more likely to have a skilled attendant. So other outcomes as well, when you involve men in prenatal care and birthing outcomes, fathers are usually involved in the long run. Overall, child development outcomes are improved. Household incomes are usually higher. Households are usually more gender equitable. And overall, there's a better health of the family. Men are more likely to be caregiving if they have more equitable attitudes and have some secondary education. This is definitely some of the global work, but also the work in the Americas as well. Men are more likely to be involved in caregiving if they were taught to care for siblings and were not exposed to interpersonal violence as a child. They usually work fewer hours and are younger if they're caregiving. They're more likely to take paternity leave if offered. And they're more likely to have a partner's child's mother who also worked and have had their own father participate in caregiving. And when men are caregivers, women's income goes up, and when men do more care work, children show more gender equitable attitudes and better cognitive and social development. Men are also involved in caregiving, more likely to be involved in reproductive health. And as a result, men's lives are better when they're involved in caregiving. In Promundo's work, basically Men Who Care, it's a study of 83 men in 5 countries, and they had life history interviews. They were selected from their primary caregiving roles and professional caregiving roles. More men are doing more care work, and they lack references for men doing care work. And that's one of the issues. We haven't really established the sort of the foundation for where men feel supportive in that. And they stressed the importance, those men stressed the importance of females' attitudes towards men's caregiving. And they had a strong sense of identity in being caregivers, but often the feelings were mixed with confusion, depression, and isolation, because it's fairly rare still to be supportive as a male as a caregiver. Caregivers' roles served an important pathway to new ways of expressing connection and emotions, which is much healthier than most men engage with others in this day and age, but we're hoping to sort of change that as we go forward. And this poses a challenge to women in social institutions to accept men in new workplace care roles. And so understanding the importance of paternity leave or family leave as we sort of now need to go for. So let's focus on breastfeeding. Studies show that when a nursing mother has a significant other who is educated about and supports her choice to breastfeed, she is more likely to be successful at it. For many mothers, this significant other is the baby's father. However, the father's support is important to be successful. The first few weeks of breastfeeding are the most challenging. But think about it. As I know from sort of sexual and reproductive health for young men and young adult men, we expect them to know a lot, but there's no one talking to them. And so if you think about the evidence for young men around sexual and reproductive health, we the main message parents, possibly even school providers, give them: if you're going to have sex, use a condom. And that's it. So, that's it. And so, but we expect men, young men, to support their partners in knowledge of their contraception, sort of help them know what to do and sort of be present and sort of have all this other knowledge. But there's nothing that gets them there. And so in the context that we don't have that support here, we have even less usually around breastfeeding and helping them support their partners. So one of the sort of thoughts and sort of to support and engage fathers, we need to educate them first about the benefits of breastfeeding, just the basics. It's like help them understand, just like, and the men sort of, it goes further. We brought up pastors. It's like at our last panel, we were talking about sort of in communities, in church communities, sort of helping pastors understand that they are the gatekeepers for a community presence to help foster breastfeeding and what that means in the church community. And it is, if they can foster that, it is usually educating men in that context so that they can support women sort of even to breastfeed in the church community and on sort of these important events for the community. We also need to answer common questions for the guys, just sort of help them know the basics. Is the baby getting enough? How can they support their mom? Is breastfeeding painful? Are my partner's breasts off limits? Or what about sex? Will she have to nurse in public? How do we help him understand what that means in the context of being in public, her being in public breastfeeding, and how can he support her? And there's sort of practical things, even at home, sort of making sure that he understands that she's doing a lot of work. She's up feeding every 3 hours. He can be supportive. He can sort of help if taught, and sort of listening to her, where to place the pillow, how to place the pillow, sort of get her, make sure that she's well fed, get her meals, help her have time to rest, be with the kids, sort of be supportive. All those things we think they're intuitive, but unless we sort of state it and sort of educate our fathers to understand their role, and that it's not just about the food, it's about everything else, but it's all supportive in sort of making this family work and for the health of the kid, it's really important. And so that nurturing a baby is not just feeding, and they can have a really important part in that process through bonding, through sort of eye to eye, through sort of skin to skin touch as well. And so as we move forward to support women to breastfeed, my premise is to help you sort of think about engaging men and in a very sort of positive and proactive way so that they can be supportive of women breastfeeding. Thank you.
Hi, everyone. Again, I'm Jessica Lee with the Center for Work-Life Law at UC Hastings College of the Law. Now, you heard me talk about education earlier, so you might be wondering, why is this education equity lawyer talking about the workplace? Well, our work on breastfeeding actually began in earnest with the Pregnant Scholar, but is now integrated throughout all of the work that we do at the center. So my colleague and I support pregnant women. We support women who are dealing with childbirth leave, breastfeeding, postpartum, really from A to Z. And we do that through supporting policy initiatives, institutional change, and then, of course, direct services to mothers. But another great part of what we do is working with the broader community who are supporting these same mothers. So often I will train attorneys on breastfeeding discrimination and what that looks like. And I'm very happy to be working with you all here today. In particular, those of you who do research, it's such a pleasure to be here with you all because I use so much of what you all create in my advocacy with employers and institutions. So very happy to be here today. So the first question is why this focus on the workplace? I think some of this might be preaching to the choir here, but we all know now that breastfeeding initiation is very close to the target. Maybe this is controversial, but for the most Americans, it is now the norm. But of course, we have those really terrible duration numbers. When you look at 6 months and 12 months of exclusive breastfeeding, there is a massive shift that occurs between the 80-something% of women who start and those who carry on. And one of the critical reasons why is this return to work. About half of women who've worked outside the home returned back within 3 months. And new studies showed that a quarter of these women actually go back to work less than 2 weeks after giving birth. So you probably would have seen some delight in Dr. Brown's face if you would have seen me nodding so earnestly at that recommendation to shift how we view postpartum care, because those mothers who are out back at work within 2 weeks are facing incredible challenges maintaining their milk supply, dealing with these challenges in the workplace. And many of them who contact us are frankly at their wits' end. We'll get through this. So what do women at work need? Well, it's pretty simple. You need reasonable break time for expressing breast milk. Some women are able to have their babies come to them. Most often, this is pumping. But 41% of women in this country do not have access to that break time. They may ask their boss if they could take not 15 minutes, their 30-minute break and turn that into a pumping break, and they're just told no. Or they're told, yeah, when somebody can cover your station. And that doesn't happen until 30, 40, 60 minutes later. There was a recent case where the worker was denied the breaks that she needed for 3 hours, and so she's working while leaking. This happens incredibly frequently, because many workers simply do not have control over their break time while they're at work. They also need a private space to be able to express breast milk. And 55% of women studied don't have that access to a private space. Most of us, I think, are fortunate enough to have offices, but the average American worker simply doesn't have an office where they can close and lock the door. They are pumping in bathrooms, they're pumping in their cars. I've talked with several students who pump in their boss's office while they awkwardly work next to them. This is a real challenge. And then when you look at the numbers together, about 60% don't have access to both that time and space. So the majority of women simply don't have what they need to be able to easily pump breast milk at work. Now, what does this add up to? Well, women who did have access to both the time and space were 2.3 times more likely to be breastfeeding exclusively at 6 months. So when you do provide them the support they need, they stick with it much more often. Eureka, go figure. We heard a lot today about education. Education of the women isn't enough. We need to have that support so that they can put this drive to breastfeed into practice, regardless of whether they have paid leave time or have to go back to work. And this effect, being more likely to be exclusively breastfeeding at 6 months, there was actually an effect after 6 months as well. It was a little bit less pronounced, but they were more likely to continue up to a year. So a question that I frequently get is, isn't there a law for that? The lawyer shakes her head. It's bad. There is a federal law called the Break Time for Nursing Mothers provision. This was actually a part of the Affordable Care Act, and it protects those workers who are covered by the overtime provisions of the Fair Labor Standards Act. So if you don't have that exempt next to your name in your employment contract, you're covered by this law. It requires employers to provide their employees with that reasonable break time as needed. So not when it's convenient for the boss, but when she needs to express her breast milk. And it also requires the employers to provide a space that's shielded from view, that's private, not a bathroom. Thank you so much for sharing that photo of somebody eating their sandwich in the bathroom, because that is one of the most frequent things we hear is that my boss says, just go in the bathroom. Often you hear that sometimes from retail workers who share a bathroom not only with their other coworkers, but with the public as well. So you can imagine what the state of that restroom is like. But a key shortcoming of this law, in addition to challenges enforcing it, it doesn't cover every worker. At best, this is going to cover just over half of American workers. It's not guaranteed for all of them that their bosses actually know about this. There's still a lot of work to do to make that happen. And then it only applies for the first year after birth. Now, there is another law, and this actually covers every worker. It's the Pregnancy Discrimination Act. For those of you following along, this is actually part of Title VII employment law. And this is a very basic anti-discrimination law, which says, essentially, if you provide it for workers who aren't breastfeeding, you should provide it for those workers who are. To not do so is sex discrimination. Some of this comparative standard is actually really clear. It should be very easy for employers, but yet you see employers all the time who don't realize that they have to provide breastfeeding breaks for their workers just as easily as they provide smoke breaks. That's still news to folks. And then finally, we do have various state laws. Most of them don't have good enforcement provisions, so I don't count on these to fill the gaps. So from the legal standpoint, we have a long, long way to come, and I think there are going to be some presentations tomorrow about upcoming legislation that will hopefully bridge some of this gap. But thankfully, there are a lot of things that physicians can do to help change this environment. We really need a cultural shift to make breastfeeding at work more accessible for women. And then we also need some added enforcement and strength behind the laws that already exist. And believe it or not, physicians can actually help fill both of those gaps. So here's what we can do, and most of this, I'm sure you know. 1, should be obvious, isn't always. Speak with your patient about breastfeeding. 2, make sure in that conversation, you encourage your patient to make a plan for breastfeeding at work in advance. I can't tell you how many times we hear from women who show up their first day back and say, oh, hey, by the way, I need a room. You know this, right? I just had a baby. Their boss did not think of that. And it creates a situation where you have a worker who is leaking breast milk, who's engorged, uncomfortable, really frantic, and an employer who has no idea what to do. And there are several cases that have actually gone up to the federal level where the employer ends up saying, you just need to go home. And the employee lost her job, in essence, because of this really dramatic flashpoint that happens right when she came back. But if you have a little bit more time, you might have a better option to be able to work this out before the crisis hits. So encouraging her to have that plan early, it really makes a difference in what she's able to negotiate. Next, if you encounter someone that is hesitant about pumping at work, speaking with her about practical solutions. I'll give you some resources for that later. And then just a simple reminder, just like we did with the teenagers, letting them know there is a law can change the entire dynamic of the negotiation. It makes it obvious that she's not alone in this. This isn't some favor she's asking for. This is an entitlement. And then finally, one of the big things that we're trying to encourage more physicians to do is to write a work note for your patients to help them be able to access the lactation accommodations that they need. I'll talk a bit more about that. So effective work notes really help bridge some of the cultural gap, and they help bridge some of the gaps that we see in the legal side of things. So the first thing that they do is they help educate an employer about breastfeeding. So we have employers all the time who they just don't understand why she would need a break every 3 hours. You pumped once, you're done. Others simply don't understand why your 15-minute break is not enough. You should be able to magically make that fit into 15 minutes. They simply don't understand the biology of it. They don't understand why it's important to the mother. One of the great things that a note can do is remind employers that this is important for the mother's health, because you frequently have employers who just say, this is a parenting choice, and don't realize that this is actually a health choice as well. This is a medical necessity, or just important to the patient's health. They don't get that. So the first thing is educating the employer about breastfeeding and pumping. Next, great effective notes are specific about the patient's needs. Again, that's part of education. That's also part of making a very clear ask that would be enforceable by an advocate helping the worker negotiate, or if things turn sour, by an attorney. So if you clearly state the need for a private place other than a bathroom and the frequency and duration of breaks, that note is going to go a long way. Typically we say as needed, but at least X, because we all know that this can change. But this will give the employer an idea of what to expect. Next, communicate that the patient is able to continue working. At times, employers overreact and think, if I can't give her a room with a fridge and a sink and unlimited break time, she's going to have some sort of crisis, and I just can't have this liability on my hands. She needs to get out. Women do lose their jobs over this. So communicating that these accommodations are necessary, but don't forget, this is a temporary condition. She is still able to do her job. That can actually save an employee's job. And then sometimes the patient may actually need additional notes. They might need additional accommodations. So if the patient or her baby has a medical condition or impairment, you need to say that. Or sometimes the work environment requires a unique accommodation. So for example, there was a recent case of an employee who just could not wear her bulletproof vest. She was a police officer. She was going to go out on the beat. If she was going to wear that bulletproof vest, it needed to be tight enough to actually work. Well, that's compressing her breast and making it incredibly uncomfortable throughout the entire workday. And the doctor was concerned that that was going to impact her milk supply. So she needed a very specific note. And this comes up. And actually having a good doctor's note, having her doctor write this recommendation that she be given either a different vest that would actually do that job and allow her to breastfeed, or a different assignment, that led to her actually being able to get a very large jury award when they fired her. Shouldn't have been fired in the first place. But if it wasn't for that doctor's note discussing the medical necessity, that case would have looked very, very different. And she might have lost her job and lost a significant amount of income that she needed to support her family. So this sounds like a lot. We're asking for very short work notes, not books. And there's actually an example of a model note that is available. You can plug into the note that's pre-written, or you can just use it as a guide of the best way to say this really succinctly so that you're not writing a book for every lactating patient who comes in. But if physicians can do this, it will help educate the employers. It will help make those legal arguments a lot easier. And hopefully we'll start to see some more of this cultural shift happening in the workplace with the support of physicians. We have tons of resources here, and I'm also very happy to speak with any of you about what you can be doing to help your patients in the workplace. Thanks.
So I want to give our panel a chance to do two things for us. One is if they want to ask each other any questions. They all have a different piece of the elephant that they focus on, so they may want to address some of their issues with their colleagues. The other is that I'd like to ask each of them to give us some guidance about, from each of their perspectives, what do you see as the greatest progress or success in the last 5 to 8 years? Partly to give us some optimism and hope for this challenge. The other is in terms of our work, thinking about the future, and I would assume everyone in the room, what do you see as the most important things to focus on going forward? Do we have a, yeah. Give me a hand. Yeah.
Let's see. I guess a challenge is a challenge is the importance of physicians to mention breastfeeding to women of color. I still encounter so many young Black women who tell me that no one ever mentioned anything to them about breastfeeding while they were pregnant. And I still hear from physicians that they read the literature, and the literature says Black women don't breastfeed. And therefore, they have 6 minutes with them. They're going to talk about what's needed. Things that they, their blood pressure and the gestational diabetes. So we say that our mothers are resource deprived. They don't get the information that they need to make informed decisions. And it's imperative that all women get that information. The success is that there really are so many more women breastfeeding. We get calls and talk to women all over the country who just say, thank you for having an innovative presence on Facebook, on Instagram. They can Skype us. And so what we do is to make sure that if there's anybody in their immediate area that they can meet them and talk to them and work with them, because it's important to us to connect people who are close together. But there truly are so many more people breastfeeding. But we always say that, they're in the hospital for 2 days. We want women to breastfeed how long? How long? 6 months exclusively, right? And then what? A year and behind. So that's at least 363 days that they're not in the hospital. So we have got to build community support, the baby cafes and the mother-to-mother networks and all those other things too.
So for successes, I think I'm a little bit pessimistic sometimes because I don't want people to put all of their faith in the law. But it is worth noting that this is the lawyer saying, don't put your faith in the law. Sorry. It's true. But I think it is important to note the recent changes in the law as very big successes when it comes to supporting women in the workplace or breastfeeding workers. The Affordable Care Act provisions requiring that those workers covered by the overtime provision be given time and space. That's huge. Before that, there was nothing specific, nothing clear on the books that folks could depend on. So that is a big leap. And the other law I mentioned, that general employment law anti-discrimination framework, which protects all workers, it actually wasn't until very, very recently, I think maybe 3 years ago, that the federal courts looked at lactation as a sex-related condition. That was still very unclear, and there were some terrible, terrible cases essentially saying, well, men can lactate too, so this isn't really sex-related, or this is a choice that the women are making, so we can't just look at it as inherent, even though pregnancy, childbirth, everything else related to them is a sex-related condition. So that's been incredibly new, which is sad that this change is happening so late, but it's a big, big shift. And I think with the support of community members and with more women being armed with the knowledge that these laws protect them, that cultural shift is going to really snowball in the next few years.
So I think some of the success and the hope, more hope than true success at this point, is just by sitting here, we're engaging the possibility of sort of involving our fathers and our young men in these conversations and hopefully educating them. And that's been an evolution on many levels. When I first got out of my fellowship, I was the only person sort of thinking about adolescent medicine from the young male standpoint, as opposed, it was adolescent medicine at that point in time was synonymous with adolescent females. And so we've sort of, more people are bringing the concept of involving men and young men in their health and sort of their partner's health than we have before, to the point where the CDC and Office of Adolescent Health have funded the first teen pregnancy prevention project that focuses only on males. And so there are 3 projects, and I have one of them. That's the first ever. So things are moving forward. This breastfeed, sort of having and engaging men and helping to support breastfeeding is another avenue. These are sort of, on some levels in my sort of concept, I know there's a lot of web resources that talk about how to engage men, but I'm not sure how proactively everyone's doing it. And I know that from a pediatric standpoint, our pediatricians aren't engaging fathers as much as we need to in conversation. So I think that's the challenge. They're not, reimbursement for talking with the other parent is not always there, but understanding how much we need to involve the entire family and not just one to support all of the circumstances is important.
Want to ask each other any questions?
Can I ask you a question? So, Deanna Dirihe, Urban Strategies. It's nice to see everyone and the panel. So, first, Jessica, and to all the physicians in the room, the website is wonderful. I know that when I talked to my doctor about getting a note, she was very supportive. When I talked to her office manager, she had no idea what to do. So being able to go someplace and use that, so send it to all your office managers. This is where to go, where you can get how to use and what a note should look like. To Dr. L and to Kim, thinking about what we talked about fathers and being involved, thinking about what we know about breastfeeding, we often go really quickly to this education, right? And it's what we do, right? We have to educate, and people just know. So having worked with Latinas in breastfeeding, and so this is a question, we found that Latinas, are breastfeed at really high rates. They start, right? They initiate, they have the intent to, but they drop off really hard. And it leads us to think it's systematic barriers. So when developing education and working with focus groups, we talked to Latinas and they said, no, we know breastfeeding is good, right? And back to this thing about not making milk. So I'm trying to put all these things together, right? And a part of me wants to, looking at what we've done with teen moms and breastfeeding, looking at what we're doing with women of color, working to recognize those implicit bias, the racial structures, because part of this is about women of color not feeling that they're enough and being told that they're not enough, right? Which manifests itself in this, I don't make enough for my baby, I can't care for my baby. And we've seen it in fathers who feel like, hands off, I don't know what to do. And so as our providers or preventionists, we're very quick to be like, let's give them just all these things about all these things that it's going to prevent, as opposed to talking about this deeper issue. So thinking about how we treat women as women and women of color as being just right for their babies, I think is something we need to figure out how to have that conversation. So I just wanted to get your thoughts about that.
Okay, because I was gonna forget if she. It's all about relationships again. Um, Usually, and it has to be modeled. It has to be mentored, and we have got to get to the place where they can go next door and know that, well, my neighbor is breastfeeding a 9-month-old, or the woman at church, or somebody I work with, because again, it makes a difference when women who look like them have been successful at doing this. And again, so it has to be in the community, and provide the resources necessary to assure that women can get information about, because we've got to make the benefits outweigh the barriers. And again, follow them home. I remember one of the babies I worked with in the NICU, they finally went home at 8 months, and she was breastfeeding, but she was on 8 medications. And I just had to go visit because, I had that baby for 8 months, and it was blood, sweat, and tears keeping that woman breastfeeding and pumping and all those things. And I just wanted to go check, and I went, and she didn't have a refrigerator, didn't even own one. She got 8 medications supposed to be refrigerated. So again, you've got to involve the community and have them trust you enough to really tell you what the barriers are, so that we can make the benefits outweigh those barriers. And it's just so hard. In many places, they wear their babies to work for a year. We had none of that. We have none of that. I've worked with women who've had a baby on Thursday and went back to work on Monday. Not just one or two, a bunch, okay? And so again, I worked with a teenager, 15-year-old, who lived in an apartment with 8 other people, and the only place she had to pump and breastfeed was in the bathroom. And we're saying, don't breastfeed in the bathroom. You don't have to do that. There's laws against that. And I'm like, oh, okay, go on and breastfeed in the bathroom. It's okay. So again, before we blah, 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 listen, be good listeners, and talk to women and help them to be successful at what they choose to do. It's not about me, it's about them.
Yeah, I can't even add it.
She had that pregnancy break. And we
No, I just heard you
Oh, no, I
telling
thought
us.
that was a long question.
I'm so happy to hear that the notes were helpful to you. One of the things that I don't think I stress enough in my presentation, but that's really important, is that the workers who have been impacted by systemic racism, um, they're the most likely to need this assistance. If you are a CEO, you can probably either turn this off. I don't know. You can either set your own hours, you can go in your own office, you can do what you need to do. If you're self-employed, you have that flexibility. If you are an hourly worker, or if you are lower on the totem pole, wherever that is, you just are more vulnerable at every stage, whether you're an office worker, a retail worker, wherever it may be. And so I think paying attention to these workplace issues is also a really big question of equity, because the people who are going to be most impacted by all of this are those who have faced barrier after barrier after barrier. So shout out those benefits, but let's tear down some of those barriers.
So you brought up that education isn't enough, and I do agree. But with fathers, you have to start somewhere, because we're not really talking to them about any of this. But I do think sort of the other sort of biases and barriers are about engaging fathers in care of their kids, particularly in the medical system, working with young fathers, particularly at times and in groups, and going to speak with them. One, I think, pertinent story came up where a young man brought his daughter to a pediatrician's office, and the first statement out of the pediatrician's mouth was, "Where's the mother?" And so really discounted who he was and what he might be bringing to the table. Not that I know that he knew all the details that the pediatrician might ask, but he was present, he was trying, sort of educate him on what he needed to do.
So I just want to thank Deanna for her question. I want to thank Deanna for being clearly model mother of two and knows from whence she speaks for these questions. And as importantly, for having been our fabulous program officer at the W.K. Kellogg Foundation, because most of us wouldn't still be here doing what we're doing, which is so important, without your support. And I really, really thank you.
Good afternoon. My name is Ivanka, once again from St. Martin. The question I have is basically about law, because right now we don't have anything in effect as yet for working mothers or fathers at all. They're busy working it through. So we have our laws is based on Dutch also, Dutch laws. And I know it's different from the American system where you have all of these guidelines put in place for parents already that can help them out. But for us that are still struggling in between, because that question comes a lot in the clinic, what can I do for my baby, knowing that I'm going back to work in the next 4 weeks, because we only have 6 weeks of maternity leave, postpartum leave. So what can they do, and how can they encourage their boss without the laws to allow them to breastfeed, pump on the job site or leave the workplace, because we're some practically close to the job to get the job done with the breastfeeding.
Yeah, so I will happily send you some resources. We have a publication coming out talking to your boss about your pump instead of your bump, which coaches women through this process. But I would say, first of all, congratulating them on having breastfed as long as they have, reiterating that they're already on the right course. Here we don't even have that 6 weeks. So I'm very happy to hear that you have that. But I think two things just sort of immediately come to mind. One is trying to put the case in their employer's language, making sure, the employer's language is money. They need to know, okay, this person is still committed to the work. This isn't them slacking off at work. This is them meeting a need within a specific time and then coming back. How is this going to impact me? Well, there are documents after documents. The business case for breastfeeding has been put out. I don't remember who put it out, but is it Office of Women's Health has put out the business case for breastfeeding. And it shows that women who are able to meet those breastfeeding goals are more committed workers. They're less likely to take time off sick. Their babies are healthier. So I don't know if your employers provide healthcare, but it actually lowers your healthcare costs as well. So unfortunately, it's not just the moral or even the legal argument being made, but it's a business argument being made that this is going to be good for that employer. So speaking in their language about why they should support it. And then the other thing is just making sure they have the resources and thinking creatively about how to accommodate. Like you said, we don't ever want to get stuck into thinking, I need X, and if you can't get X, you're out. There are solutions for every field. So farm workers have little tents that they use to breastfeed their babies in the fields. People on construction sites have similar safe spaces they can go to do it. So again, the Office of Women's Health, the Department of Labor here in the US has some really great publications, and I'll happily connect you with some of these resources because we've thought through all of this. We just have to get it into their hands, make it easy for them.
Is your hospital baby friendly?
Yes, we are. That's a start, but we mostly have that problem within the working field. So, for instance, most of the people or the lower class people are employed by retail stores. So, if for instance, a cruise ship is coming in and they have a stock of stuff to offload, and you just made your baby 2 weeks ago, hi, I need you in at work by 7 p.m. tomorrow because we need to offload the trailer. So, a lot of parents are stuck with that question and they are going to the medical healthcare facilities and asking, what can be done? I just had a baby. I cannot return. But if they refuse to go to work, they get fired. So
And one sort of interim legal measure, like, oh, sorry.
Should have gave us that look. We got to go.
Let's talk.
Yeah. You're not going to get me in trouble with that.
Well, I hate to be the ugly one here, but please thank our panel